It turns out that in a lot of the studies that underlie those clinical decision rules, you find the exact same problem. And so, for example, who is at risk for head trauma in a way that would require a head CT? And what you found is that how did they measure who needed a head CT or like who had head trauma? Well, it was people who got head CTs in the current system of care. But obviously, some people that we might care a lot about are the ones who have an intracranial injury that was missed by doctors. And those people are actually going to be absent from that, population that's going to be considered high risk. These clinical decision support tools were trained in coding disparities and problems with those care practices that we see today for future generations to keep making the same mistakes.
Welcome to the Digital Pulse, a podcast from MPJ Digital Medicine, where we explore the ideas, innovations, and people shaping the future of healthcare. I'm Dr. Benjamin Mazer, a medical journalist and practicing pathologist at Johns Hopkins University. In this episode, I talked to Dr. Ziad Obermeyer, an emergency physician and Berkeley professor whose work on algorithmic bias has reshaped the field of artificial intelligence. Dr. Obermeyer offers us essential insights into how to make AI algorithms both equitable and effective. I hope you enjoy this conversation. And if you do, don't forget to rate us 5 stars and subscribe. Thanks. All right. Thanks for joining us, everyone. Welcome to another episode of the Digital Pulse, the podcast by MPJ Digital Medicine. We're really lucky to have Dr. Ziad Obermeyer, a professor at UC Berkeley School of Public Health and a practicing emergency medicine physician. He's, I would say, one of the most important voices in the modern artificial intelligence world. I think Time Magazine also rated him one of the most influential voices, so I'm not alone. My rating is a lot less meaningful than theirs. Anyway, amazing guy, and we're lucky to have him. I'd love to kind of start with algorithmic bias, which I think is one of your sort of claims to fame. I remember it as kind of the big turning point was your paper in Science a number of years ago, 2019, I believe. So I'd love to kind of hear briefly kind of how that paper came into being and sort of where it went from there, and then we can kind of touch on some more contemporary things.
Yeah, thanks, Ben, for that lovely intro. Maybe I'll tell you a little bit about the twists and turns, since this is more like a director's cut, version of a conversation rather than the official story. So, like most research projects, this started with getting access to a data set. So I was working at the Brigham and Women's Hospital in Boston at the time. And so, one of the things that you and listeners know is that when you have the good fortune of being based at an academic medical center, you get access to the data that is lying around in that academic medical center's data warehouse. And at the time, there was a lot of enthusiasm, still is, around how to use artificial intelligence to help do population health management. And in many ways, this is kind of a AI and population health, or like a peanut butter and jelly sort of situation, because you've got a population of patients. Some of them are going to get sick. You don't know which ones. If you did know which ones, there's probably some things you can do to help them today to prevent them from getting sick tomorrow. And AI is really great at predicting things that are going to happen in the future based on data that are available today. And so there was a lot of enthusiasm for this in policy circles, but also in business circles. So a lot of vendors were starting to sell software to hospitals and to insurers to help them make decisions about which patients get access to population health management. And so we actually, the hospital system where I was working had purchased one of these software packages and was using it to help them with their decisions about like who gets access to population health. So the way it would work is couple times a year, they would run the algorithm. The algorithm would make a prediction about, oh, these people look very high risk. And those people would get automatically enrolled into a high risk care management program. For a bunch of other people, they'd get shown to their primary care doctors, and the primary care doctor would be able to say, yes, this person is good, this person is not good, et cetera. And a bunch of people just get screened out. Okay. So we were actually interested in, does population health management work? And it was really nice because these algorithms were using very sharp thresholds for who gets enrolled and who gets shown to their primary care doctor and who gets screened out. So we're like, great, we're going to run that study looking at those cut points and looking at people above and below the cut points who got more or less pop health. And we're going to try to estimate the effect of pop health on, future outcomes.
This is
And
like a dream natural experiment, by the way, for people listening. Things with sharp cutoffs are like make economists salivate and stuff. So
absolutely. So we were salivating, and then it turned out that the data set was way too small and too noisy to do it. And it just there were a bunch of problems with it, which, I think many listeners will sympathize with this. Things don't always work out the way you think they're going to when you start doing research. That's why it's research. So we were sort of scratching our heads and trying to figure out, oh, what do we do with this data set? And then we remembered, at the beginning of an analysis, when you go back and look at, you just look at the summary statistics. It's like, yeah, Black patients did have weirdly low scores. That was weird. Maybe there's something there. And so that's actually how this paper came about, was because we couldn't do the thing that we thought we were going to do with this data set, but we had access to the data set, and we'd noticed this odd fact. And so the fact was that if you looked at two patients who looked pretty similar in terms of their health, like whether they had heart failure, how many chronic conditions they had, things like that, Black patients had scores that were quite a bit lower than white patients. And so that empirical observation was the thing that led us to do an audit of this algorithm, and its ability to predict future outcomes differentially by race. So what we found was, that the fact was true. So that held up, that if you looked at patients who had the same number of chronic conditions or the same actual conditions, but because we had electronic health record data, we even saw this based on, hemoglobin A1C or, blood pressure, things like that. Black patients were being systematically rated as lower priority for population health management. And so they were getting less access to high risk care management programs. So these are these programs where, you get a hotline to a nurse practitioner or somebody who can just help you. It's like, it's like one of those elite status programs on an airline. There's like a human who picks up your call. They can fix your problem, and you have set aside primary care slots for you. And so Black patients were being deprioritized for all of that helpful stuff. So that was the fact. And that was, just to give you a sense of scale, this particular algorithm, like the specific software that we were studying, by the developers' estimates, this is being used to screen 70 million people per year in the US. And the family of algorithms that works like the one we studied is about 150 million people per year. So like most of the US population is being run through one of those things, unbeknownst to us, on the back end of health systems and insurers and things like that.
Yeah.
So why did this happen? Here's the basic intuition is, when we were like, when people think about population health management, what can AI do? It's going to predict who's going to get sick. And when we're talking, human to human, and I say get sick, you kind of know what I mean. It's like, yeah, someone's going to their heart failure is going to decompensate, or they're going to have some diabetic complication or something like that. Algorithms don't know what you mean. And so for algorithms, you need to write down exactly what you mean. And it turns out that there's no variable that's called get sick in the electronic health record or in claims. There's just a bunch of there's hemoglobin A1C, but that's not measured for everyone. There's diagnoses, but sometimes things aren't diagnosed. And then you need to group them into comorbidity groups together. And it's very messy. And so what all of these software developers did when they were training these algorithms is they're going to like they said, we're going to abstract from all of that complexity and we're going to train algorithms to predict total medical expenditures, costs, instead of engaging with all of this health data, which is messy and annoying. And it's actually kind of a smart solution because when people get sick, really rack up healthcare costs. The problem is that not everybody racks up costs at the same rate because not everybody has access to the healthcare system. And some people, when they get access to the healthcare system, they get treated differently. And so we've known for a long time that Black patients actually have lower medical expenditures conditional on their health, any measure of health that you want to use because of those barriers to access and because of differential treatment. And this isn't, we focused on black white in that paper, but this isn't just a black white issue. This is an urban rural issue. This is an educational and socioeconomic and, all of the structural factors that affect people's access to healthcare are going to have the same thing of you can be sick, but you're going to cost less because you get less care because of those barriers to access. And so the algorithm was seeing those patterns in cost and then encoding them as policy and saying, oh, I see that you're actually, sure, you've got a high hemoglobin A1C and you've got all these problems, but you don't end up generating a lot of costs. So I'm going to deprioritize you for access to high-risk care management, which is the exact opposite of what we want to do. Those are the patients in whom, not whom, we can just help with their health, but in whom you can get savings by getting them access to care early. So even if you just wanted to reduce costs, those are exactly the patients you'd want to find. And those are the patients that the algorithm was missing.
Yeah. And I think what strikes me especially is the scale of these things. That is the modern part. We've always had different ways of picking out patients, and we'll kind of talk about some of your more recent work. But these things became scaled at such a level very quickly and almost invisibly that even small biases get amplified or are pervasive.
Absolutely.
Yeah. So when the paper came out, I think there was a big response, but I'd love to hear what your perception of the response was, positive, negative, that kind of thing.
Yeah, I think it was fairly surprising to me how much attention the paper got. And certainly none of my other papers had gotten that much attention. No paper since then has gotten that much attention. I think it highlighted two things. One is that, of course, there was a lot of attention to race and disparities always, but particularly at that time in 2019. But I think the other important chord that it touched was that there are a lot of AI tools that are being used everywhere in society, not just in the health system, but in lots of other places. And there's just not a lot of evaluation of whether these things are doing their job. And so in the health system, for any other new technology, if it's like a drug or a device or like whatever, there's you can quibble with how it's done, but there's a lot of attention to figuring out, does this thing work? And, should we be using it? And a lot of these AI tools actually manage to bypass a lot of that evaluation structure that we have for other new technologies in medicine. And so, as you mentioned, these things got to a crazy large scale without really having been subjected to any scrutiny, regulatory, scientific, or otherwise. And I think one of the reasons to go back to where I started this conversation was it's really hard to get access to the data that you need to evaluate these tools. And so the vendor has access to their data, but even their data are not that great because they're training on the data that they have access to. But then, of course, they want to apply the algorithm to data that they don't have access to. So how do you know it's working on those new data? You don't. And as anyone who's tried to get access to healthcare data knows, it is really hard to get access to data that you need to evaluate algorithms, to build algorithms, just to do any kind of research, like quality research, health services research. So access to data, I think, is a huge bottleneck, and it's one of the reasons that a lot of these tools can essentially get scaled up without really having been evaluated.
Do you think we even know if we're making progress on removing these sorts of biases, if there's so much that's sort of blocked by commercial interests, IP, trade secrets, the sort of veil of veil of capitalism, you know, uh, I mean, how would we even know if we're making progress? I think a lot of people do care about this now,
Yeah.
but do we have any sense?
Yeah, it's a great question. I mean, I think that there are certainly a lot more papers being written, like auditing algorithms that are deployed, and that's true in health. It's true in, a lot of other areas where algorithms are being deployed. There's a lot of work, for example, auditing things that are being used in criminal justice, in social services, things like that. So I think a lot more people are now paying attention, and there's more scrutiny. I think the data bottleneck is still very real. And I think I can just tell you about because this is an issue that I care about a lot. I'll tell you about one thing that I've been doing recently, which is a few years ago, I helped set up a company called Dandelion, which formed a consortium of big non-academic health systems and brought together all of the data from those systems. So both the structured data from Epic, Cerner, but also the images and waveforms and whole slide images and everything, and brought all those data together in a place where people who wanted to build clinical AI tools could build those tools, but also people who wanted to evaluate tools could run those evaluations. And so the American Heart Association, in partnership with that company, has set up an AI assessment lab where people who have AI tools and are interested in evaluating their performance outside of the data where they were trained can actually submit the algorithm to the AHA assessment lab. The AHA will run those tools in the data put together by this company and come back with a report on how that algorithm is doing overall, and importantly, how it's doing in different protected groups, racial, gender, age, but also like different device manufacturers that you might have trained your ECG tool on a set of GE Muse ECGs, but you want to know how it works in Philips or other manufacturers. And because of the breadth and diversity of the data that we've put together, we can actually make those breakdowns and show how algorithms are doing across these important dimensions. And so, I think we're not the only people who are doing this. I think there are more people who are desperately trying to bring data online to do this kind of thing. And I think that's really positive and needed.
So making it easier for companies and organizations to sort of stress test their algorithms, that's maybe where you see the
Yeah,
value.
perfectly put. And also, I think bringing in professional societies and people who are interested in evaluating and regulating algorithms as a way to sort of set the goalposts so that the market can sort of aim in the right direction.
Yeah. I mean, I think those market-based solutions probably are going to be important. It's sort of a market-based problem in large part, but there may be a role for regulation also. I know you've spoken to a lot of policymakers. Has there been any movement on that front, or what would you like to see happen?
Yeah, I think one of the kind of really funny experiences that I got to have as a result of this paper was testifying in front of a Senate committee, which was yeah, that was quite a striking experience.
Mhm.
I think the regulatory apparatus, everything in government moves a little bit slower than anyone would like, including people in government. And I think in addition to the normal way that government works, I think there's also another problem here, which is that there's just some fundamental uncertainty about how we should be regulating these things. I think that over the past, 50, 60 years, we've built up a lot of infrastructure for evaluating new drugs. So we basically know how to run trials. We basically like industry knows what the FDA is looking for. The FDA knows how to interact with industry. But that took a really long time to set up. And I think now that we've got this new technology, we're all trying to figure out how to use it. I think I'll just mention one thing about this. What we after we found this striking racial bias fact, but before we published the paper, we actually got in touch with the company that made the algorithm we were studying, and we um, let them know about our findings, and we offered to help them fix it. And they were actually super responsive. In a sense, they weren't trying to do the wrong thing. They
Right.
effectively, the whole industry just had made an error. And it's like understandable because we're all just figuring out how to build these tools and how to evaluate them. And so I think that in the setting of that uncertainty, it's particularly hard for government to step in and set clear rules because things just aren't clear. And so I think that makes it even harder than normal for regulators to regulate.
Yeah. It's hard to navigate those trade-offs. And so if the trade-offs are kind of murky, where do you draw the line in policy? Sounds kind of difficult.
Absolutely. Yeah.
Yeah. Um, I'd love to pivot a tiny bit to a paper you helped with in our journal, MPJ Digital Medicine, on clinical decision instruments and algorithmic bias. Uh, clinical decision instruments are kind of like the pen and paper algorithm, the black and white television that we grew up on that now is probably feels very old fashioned. But I think of it as the sense that it's something that simple and understandable that helps doctors make a particular decision regarding often whether to start a treatment, whether to run an imaging test. There's a variety of things, but kind of you have a discrete clinical decision point, and it's a way to guide the doctor in a categorical way. And usually the input on these things, I think, is relatively simple. Information that's available in the medical record, age, gender, laboratory values, clinical history that you can ascertain. It's not big data in a sense, it's small data. And so your group looked at MD Calc, which is sort of the Wikipedia of these clinical decision instruments. It's something that doctors use, a bajillion times a day, or they use the app on their phone to kind of calculate these things. And you found what seems to be, quite a potential for algorithmic bias, I would say, things present in the data that raise concern for that. And so I'd love to hear kind of what prompted this, what you thought of, and how we sort of navigate that, because some of this is sort of just a flag that there may be bias rather than a sort of in-depth analysis of each algorithm.
Yeah, very much so. But I think the principle is right, and it's exactly as you said. Everybody now is paying attention to AI as a way to make automated data-driven decisions. But we've had these tools for a long time, and actually, like nobody had looked at those tools through that same lens. And so for me, what was very interesting in doing that study was, so when you've got an algorithm, like you're training an algorithm, you have to set up a data set and you have to set up, okay, here's the set of variables I'm going to use to predict the thing. And then here's the thing I'm going to predict. And that, in the study, the example we talked about in population health management, that went very wrong, not because we had the wrong predictors, but because we were predicting the wrong thing. So these algorithms were predicting how much was somebody going to cost over the next year as a proxy for, are they going to get sick and do they need help over the next year? And while those two things are correlated, they're actually quite different in important ways, and more so for people who are locked out of the formal health system. It turns out that in a lot of the studies that underlie those clinical decision rules, you find the exact same problem. And so, for example, there are these rules about who is at risk for head trauma in a way that would require a head CT in the emergency room or something like that. And what you found is that how did they measure who needed a head CT or like who had head trauma? Well, it was people who got head CTs in the current system of care. But obviously, some people that we might care a lot about are the ones who have an intracranial injury that was missed by doctors. And those people are actually going to be absent from that, population
Yeah.
that's going to be considered high risk. And so, in a funny way, just like that AI tool, some of these old school MD Calc clinical decision support tools were trained in a way that would have the exact same problem of encoding the care practices and all of the disparities and problems with those care practices that we see today for future generations to keep making the same mistakes.
Yeah. And I feel like there's sort of a paradox here in the sense that it almost seems like more approachable, but also more intractable because when you've got these large, insurance companies or other care organizations sort of using modern algorithms, it is the kind of thing that if you flip a switch or you change something, you can affect millions of people at once. But these are algorithms that largely are being used by individual doctors on a patient by patient basis. So
Yeah.
changing that just feels a lot harder. You can't go to every doctor and tell them what to do. And in fact, even changing the sort of calculator is difficult because they're based on these prior clinical studies that are going to be very hard to repeat. The fact I think that they were so evidence-based may be a problem because it's hard to justify completely rerunning a study, with a slightly different outcome. And so, assuming some of these biases really do pan out in affecting the output in a meaningful way, I mean, do we go about this one by one on MD Calc? I forget the number of algorithms you've looked at. I mean, I think it's hundreds. Like, how do we even go about fixing this?
Yeah, it's such a great point, Ben. And I think my one of my frequent co-authors and who also was on this science paper that you mentioned, Sendal Mulanathan, he's actually a behavioral economist. And he spent, decades trying to figure out how to change people's behavior. And I think the conclusion of, a lot of study of human behavior is that it is really hard to change human behavior. And so for him, studying algorithmic bias as opposed to human bias, it was just amazing because, yeah, you could just change this thing in the code, retrain the algorithm, and then all of a sudden the algorithm is unbiased. And it's great. So I think your point is exactly right that even though, in some level, what's scary about algorithms is how quickly they can scale up and encode all these biases. The glass half full view is like, yeah, but you can change them and improve them just as quickly once you know that there's a problem. And that's a lot harder with human biases and human behavior.
Yeah.
I think, a lot of these studies, one of the core problems is it's a problem that we've had in medicine for a long time is how do we measure the thing we actually care about? Like we don't get head CTs on 100% of people, which is good, but that means that we're missing some problems. We don't get cardiac catheterizations on everybody who comes into the emergency department, even though it might feel like we're consulting cardiology or others more than we should. But we only see the thing that we care about in a very small percentage of people, and we don't always make the right decisions. And so we're often in the situation of not having the right variables to measure. And I think, just as you said, it's a really hard problem to fix because it would involve going back and redoing all of those studies, which is hard.
Yeah. I mean, the other ironic part of this is I think it's been difficult to get physicians to adopt these clinical decision tools. I think we all recognize that individual doctors making kind of off the cuff decisions had its own potential for bias. I think that's an old idea that's panned out to be true. And so the idea is that, you use the calculator and you'll prevent some of those human foibles. And so it's been very hard to get doctors to use them. And I think we certainly are making progress. I think they are being adopted pretty regularly in a lot of domains. And so now you're coming along and saying, oh, you adopted it, but actually you're causing a whole bunch of other problems by doing that. I don't know how people are going to respond to that.
Yeah, it's not a great message for sure. I will say I have, even though a lot of the work I do is on, how to make better decisions using data, I do have a lot of sympathy for the people who look at these decision rules and basically say some version of like, this doesn't apply to my patients. And like, And it's because, it's not a statement about like, do the rules help? Because we know that structured rules help humans think. So it's like, there's no question that we should be using these rules to help us think. But the basic critique is kind of true that, if you take uh, heart attack, so there's, this is like something that I was taught in residency. There are these scores of how you assess people in the emergency department for their risk of the person in front of you having an acute coronary syndrome, a heart attack. And there's five variables there. It's the heart score. I forget what it stands for, but it's like five variables. Some of it's the ECG, some of it's age. I don't think anyone in their heart of hearts really believes the claim that heart attack is as simple as five variables with
Right.
integer weights. And in fact, the explanatory power of these scores is not great. It's not like they explain the range of variation in heart attack very well. And so it's just like, I think it was always a bit of a hard sell because we all know that heart attack is more complicated than the number of variables that a human can enter into an MD Calc web interface.
Yeah.
So I think that is one of the things that makes me very optimistic about AI tools is because they can actually do a much better job of engaging with the complexity of the underlying data in a way that traditional tools can't.
Yeah. And it sounds like you're saying maybe presumably we will still have doctors in a few years, I'm hoping. But there still is a role for the doctor to use intuition, experience, to sort of use their own hard-earned heuristics to kind of recognize when there's a deviation or something, the output doesn't apply to my patient. I've always been a big evidence-based medicine guy. That's probably how we connected at some point. And, I remember learning about all these tools and thinking about how great they were in school. And as I actually gained more and more real life practice experience,
Yeah.
I'm so tempted to be like, this doesn't make sense. I'm smarter than this. And I have to say, like, sometimes probably I'm making a good decision to go with my gut, and sometimes probably a bad decision, and I won't know which one is which unless someone studies me. But um, you know, there still is a role for that. I'm curious if you've had it affect your practice, both this sort of algorithmic bias work and just your sort of broader project. Do you think it's impacted the way you practice emergency medicine?
It probably didn't so much. So my wife and I had twins 2 years ago,
Oh,
and so since
congratulations.
around that time, I've been trying to figure out how to still be a doctor. So I haven't actually been in an emergency department for over 2 years, probably almost three now. Um, it's
So
going to
you've
affect.
slept through the entire like Chat GPT era of medicine.
Yeah, yeah,
You're going to
yeah.
be shocked. I think even as familiar as you are with these tools, you might be shocked when you get back.
I think the thing that we can talk about this later if there's time, but I am actually um, starting my own practice that's going to be effectively an outgrowth of my lab, where I'm going to try to apply some AI tools that I'm building to specific patients and specific problems. So it will definitely affect me in that. I think, here's, I think maybe the crispest way that it affected me is I think it gave me an appreciation for what's in the data versus what's not in the data. And so, I think whether we're talking about these clinical decision support rules or AI tools, um, when you can get variables into a data set and run a model on it, whether that's a regression or a machine learning model or whatever, that's always going to do better than a human can do in finding the patterns in those data. And so when there's a task that's basically fully written down in a data set, it would be very foolish to think that you're going to do better than the algorithm on that task. But there's a lot of things that are not written down in the data.
Yeah.
So until we have continuous ECG monitoring of everybody and video and audio recording of like 100% of things that are happening, you're always going to, when you're talking to a patient or looking at something, you're going to be taking in stuff that's not written down in the data set, and therefore that no algorithm has access to and no algorithm has learned from. So, how is an algorithm going to learn that the person hesitated a little bit before they answered something, and that probably means that you should ask some more questions on that. So eventually, as we get a lot of audio and
Yeah.
voice to types that are good at doing that thing, but right now, you don't want to rely on the algorithm for things that are not in the data. And so I think thinking about that as the what is the role of the human in today's health system, but especially in tomorrow's health system, it's leaning into those things that are not in the data. Like that's where our job security is going to come from. It's in figuring out what's not in the data and thinking about those. And it's in going out and collecting more things that are not in the data that no algorithm has ever had a chance to learn from.
Yeah. I think that's a really great point. In the last few minutes, I'd love to kind of pivot completely, and as someone, you're on the West Coast, you're in the AI world, you're in the medicine world. I'd love to, I think there's this huge trend of health optimization that uses, big data, laboratory data, imaging data, that uses algorithms, that uses machine learning. I mean, this is becoming, I think, a hugely influential thing, and especially with the current administration, I think is embracing it, with wearable devices and that sort of thing, like this sort of self-optimization kick. I mean, as someone straddling these worlds and maybe living in that kind of a community, I'd love to hear what you think of it. Do you think we're on the right track? Is it kind of going off the deep end?
I mean, certainly there are parts of it that are going off the deep end, but I think that's probably inevitable for any new and exciting thing. I think largely I'm very excited about the ability to collect data anytime and anywhere at like zero cost with wearables, with a lot of things.
Yeah.
Because for so long, like basically the science of medicine has been built on collecting data in very thin slices at very unrepresentative times in someone's life. So, like when you go in to see a doctor, something is wrong. But that means that we don't have any data from when things were going just fine. And I think that now that we can, like, there are very cheap wearable ECGs. So, like, I actually, like, now when I go to the gym or go for a run, I wear, do I have it here with me? I don't have it here in front of me. I actually just wear an ECG, single lead ECG monitor. It clips into like a heart rate monitoring band. And I can actually see when I do an interval on the bike, I can see a little ST deviation in my own ECG. That's super interesting. I can get a very good sense of like what my normal morphology is, how it changes with exertion, all of these things. And so I think it opens up not just sort of a new like a new data set, but kind of a new way of generating medical knowledge by having such dense measurement of the same person over time and being able to see how those measurements change with different environmental conditions and treatments and things that you're doing. So for me, this is actually really, really exciting. I think there's a lot of things that need to be figured out. It's not ready for prime time just yet. But overall, I'm very positive on the potential of this to give insights into, not just when things are going wrong, but that help us better understand when things are going right.
Yeah. I got to say, maybe you're making me more excited about it because, yeah, I mean, I think one of the hardest problems in medicine, one of the most dangerous issues is defining normal, right? And it's very hard to define normal, both in the data and due to all sorts of biases. And it's true, all these kind of easy wearable devices and just other things, I mean, mass data collection, surveillance, things we often think of in a negative light are also capable of capturing a lot of normal that wouldn't normally be captured, right? Most people don't normally have EKG strapped to them for no reason. And now that we have enough crazy people like you doing it, we're getting really good data on what's normal. Um, you know, and so that does sound very promising. I like the idea, on a sort of population level. I wonder though, using it on the individual levels where I think it gets a little scary. Like, are you very chill about your EKG, changes, or does it start to worry you when you start to see little changes on your thing?
Yeah, to go back to your earlier point about you know, algorithms versus humans, I think certainly if you were sending all of this data to an interventional cardiologist or to who, like maybe they wouldn't be that chill and maybe they'd, start activating the cath lab pretty often
Yeah.
because they're just going to react to any change in that ST segment, no matter what it looks like. But I think the thing about algorithms is that you can tune them and you can set the operating criteria in a way that actually is cost effective and maximizes value to the patient and to the healthcare system. And so you have a lot more control over these tools than you would if you were handing those data to doctors and letting them react. Um, I think the other, one other potential concern that a lot of people worry about is like, well, right now, all of this data is coming from, people like me, sort of like affluent people who live in the Bay Area. And how does that, how fair is that? How much insight does that give us into the rest of the world? One encouraging thing I'll just tell you from some of my work is the every time I've built an algorithm based on an ECG or an X-ray or some kind of like signal coming directly from a patient that's like a physiological or a biological readout, those things tend to generalize really, really well across time and place. So we've got algorithms that we've trained in Sweden that actually generalize to rural South India, like incredibly well, to Taiwan, to Southern California,
Wow.
because everyone's heart is kind of wired the same way in a way that like everyone's electronic health record data or claims data is absolutely not wired the same way in these different places. And so there's something very exciting to me about being able to have algorithms that are anchored in that physiology and anatomy and biology, which is a lot more constant than the social structures that are put on top of it that we get our most of our measurements from.
Yeah.
Yeah.
It's really amazing. It's almost like removing the the biased human perception into getting to something, the commonality in all of us. Yeah.
Yeah, very, very nicely put.
Yeah. Well, since this is technically a podcast for our journal, I'd love to just end with a quick scholarship question on how can journals like ours deal with algorithmic bias, like screen papers for this potential, alert authors to it, help reviewers address it. I mean, what should we be doing from the journal side?
Yeah, it's such a great question. And I have maybe like a non-standard answer, which is, I think in at least the popular discourse on algorithmic bias, a lot of the attention focuses on, does the algorithm see race? Is it aware, like, does it have access to the race variable or to the zip code variable? Or a, a lot of the attention is focused on the variables that are being used to predict the thing that I care about. And I think all of the research that I've done suggests that it's much more important to have absolute clarity on what is the thing I'm predicting and how is that thing measured. And I think so often in journals, and especially when journal articles get translated into social media posts and newspaper articles, they'll say things like, "This study was able to predict depression year in advance." You're like, depression, huh? I wonder what that means. And then you dig into it, and what it means is an ICD code, a billing code for depression that entered into the electronic medical record as the result of a transaction between a health system and an insurance company. So that sounds a lot less good than I can predict depression, but it is a lot more accurate. And I think it gives you much more insight into where that algorithm is going to go wrong. For example, in people who are underdiagnosed and who are not insured and who have all of these other problems to getting accurate data collection. And so I think what I would do is just make it super transparent whenever you're dealing with a clinical decision support rule or an algorithm or whatever, so that everybody can see not just like the high level summary of the thing that this algorithm is predicting, but makes it very easy to understand what is that variable exactly and how did it get measured, and was missing assumed to be zero or like, so I think highlighting those kinds of issues is maybe the highest impact single thing that any journal can do.
Yeah. So we've had Ziad Obermeyer here. Thank you so much for joining us. This was really engaging and gave me a little more hope, I think, that we're going to actually be able to handle this problem and tackle it. So thank you so much.
That's terrific. Then I've done my job as a salesman of artificial intelligence, I guess.
You've been listening to The Digital Pulse from NPJ Digital Medicine, a new podcast where we explore the ideas, innovations, and people shaping the future of healthcare. I'm Dr. Benjamin Mazer. Thank you for joining us. If you've enjoyed this episode, be sure to follow the podcast on your favorite podcast app. New episodes will also be broadcast live on the Cassini platform. And check us out on X at NPJ Digital Med. I hope you'll join us next time.